Hello and welcome to the first part of the Coronary Artery Disease lecture series, Hyperlipidemia and Atherosclerosis. The objectives of this lecture are as follows. Develop an understanding of the pathogenesis of hyperlipidemia and atherosclerosis. Analyze laboratory and physical examination findings to support the diagnosis of hyperlipidemia and atherosclerosis. And finally, apply pharmacologic and non-pharmacologic modalities to the pathogenesis of hyperlipidemia and atherosclerosis to prevent or alter the pathophysiologic ramifications of the disease process. Coronary artery disease is a disease of the coronary arteries resulting in a group of conditions. It's also known as ischemic heart disease, as well as coronary heart disease. It's a typical precursor to an acute myocardial infarction, or AMI. It's primarily caused by atherosclerosis and associated risk factors. Complications of coronary artery disease include acute myocardial infarction, heart failure, arrhythmias, sudden cardiac death, and cerebrovascular accidents. Although not always precise, this model provides an excellent depiction of the progression of acquired cardiovascular disease in adults. The individual typically begins with risk factors, including hypertension, hyperlipidemia, diabetes, and smoking, which then progresses into atherosclerosis, which progresses to coronary heart disease, then myocardial ischemia, then coronary thrombosis, which progresses to myocardial infarction, which produces arrhythmias and ventricular dysfunction, which results in remodeling of the heart and ventricles, which leads to heart failure and ultimately death. The driving force of this process is a variety of neurohormonal mechanisms. The neurohormonal model shows us that when there's an insult to the heart, cardiac dysfunction results in decompensation, where there may be an increased stretch of the ventricles, increased resistance that the ventricles have to work against, decreased squeeze of the ventricles, and decreased cardiac output. The activation of neurohormonal mechanisms attempt to compensate for these changes. Of particular importance, the renin-angiotensin-aldosterone system results in sodium and fluid accumulation, as well as vasoconstriction through the action of angiotensin II and aldosterone, respectively. Also, catecholamines such as epinephrine and norepinephrine contribute to vasoconstriction as well as adjust heart rate. This process works for a short period of time, but ultimately the same result of fluid volume overload will occur if there's no intervention. Let's first take a look at hyperlipidemia. This image from Karch provides an excellent summary of fat metabolism and its contribution to hyperlipidemia and atherosclerosis. We'll take a closer look at the pathogenesis of hyperlipidemia to clarify some key processes. Lipid metabolism can be broken down into two pathways, the endogenous and exogenous pathway. The exogenous pathway refers to outside the body. It's what we eat. The endogenous pathway, on the other hand, begins with the liver, which takes very low-density lipoproteins that it produces, leading to low-density lipoprotein and high-density lipoprotein formation. So starting with the exogenous pathway, dietary fats are ingested, then transported to the stomach, then to the small intestines where they interact with bile from the gallbladder. Fats in the form of fatty acids are combined with bile salts and broken down into micelles. They are then absorbed through microvilli in the intestinal wall and are combined with phospholipids, converting the molecule into a chylomicron. They are then picked up by the lymphatic system and circulate to the liver. In the liver, chylomicrons are synthesized into very low-density lipoproteins. Lipase converts very low-density lipoproteins into low-density lipoproteins, which can be metabolized by cells. Once the cell's energy needs are met, low-density lipoproteins then become free-floating and contribute to plaque formation. High-density lipoproteins are synthesized and secreted by the liver, and they act as scavengers, picking up cholesterol or low-density lipoproteins and returning it to the liver for breakdown. Therefore, high-density lipoproteins have a protective effect. Here is a simplified model of this process. Here you can see that the liver releases very low-density lipoproteins, where it is converted to low-density lipoproteins in the periphery. When there's an excess of free-floating LDL, the patient becomes hyperlipidemic and plaque development occurs. Basically, there's an overabundance of fat and it spills out in the periphery. Plaque development can result in myocardial infarctions, cerebrovascular accidents, peripheral vascular disease, and carotid stenosis, among other things. However, if the patient has enough HDL, the LDL can be carried back to the liver for reprocessing and breakdown. There are different types of lipoproteins. This image shows a good comparison between the different types of lipoproteins and their composition. You can see here that the molecule becomes progressively smaller as it's processed. Intermediate density lipoprotein is in between very low density lipoprotein and low density lipoprotein and can convert back and forth. VLDL and LDL are the most damaging lipoproteins. High-density lipoprotein, on the other hand, is the most refined molecule and is considered the good lipoprotein because it carries LDLs back to the liver for processing. I've left more information in your notes that further describe each of these molecules for you to review. Let's talk briefly about why the heart is so susceptible to insult from hyperlipidemia. The heart is vulnerable to ischemia or reduced oxygen delivery because of the following factors. The heart normally extracts 75% of the oxygen delivered, whereas other tissues only extract 25%. In fact, the first part of the aorta branches into the coronary arteries in order to perfuse the heart. The heart also has a limited ability to increase blood flow to it via collateral vessel development. And finally, when the heart experiences ischemia, the myocardium functions abnormally, has ineffective contractions, and a reduced cardiac output. There are some key differences between the myocardium and skeletal muscle. For instance, resting skeletal muscle uses only part of the blood's oxygen content. During exercise, skeletal muscle can function briefly by extracting more oxygen and utilizing anaerobic metabolism without increased blood supply. On the other hand, cardiac muscle extracts almost all of the blood's available oxygen. And with its limited ability to metabolize anaerobically, cardiac muscle must have increased coronary blood flow to supply oxygen and nutrients during physical activities. The key point here is that when oxygen demand exceeds oxygen supply, the heart becomes vulnerable to ischemia, injury, and necrosis. There are a variety of factors that cause this imbalance. The focus of this lecture will be atherosclerosis. However, other factors such as coronary artery steal, ischemia, physical exertion, emotional upset, ventricular hypertrophy, anemia, valvular disease, and hypoxemia can all cause an imbalance. Now let's discuss atherosclerosis in a little more detail. Atherosclerosis is the most common cause of cardiovascular disease in the United States. It's an abnormal accumulation of lipid substances and fibrous tissue within and beneath the intimal layer of the arterial blood vessel walls. This image compares veins and arteries. Both veins and arteries are comprised of 3 layers: the tunica intima, media, and externa or adventitia. You can see that the primary difference between the 2 vessels is the thickness of the tunica media, and also arteries have elastic fibers that help maintain patency in the face of high intraluminal pressure. The pressure force is greater in arteries compared with veins. Coincidentally, it's these elastic fibers that are problematic in aneurysms. The first step in the process of developing atherosclerosis is endothelial damage. This can be caused by smoking, hyperlipidemia, hypertension, hyperhomocystinemia, hemodynamic factors, viri, toxins, immune reactions, and diabetes mellitus. This image shows the response to injury following lipid deposition beneath the intimal layer of the artery. Endothelial dysfunction results in smooth muscle cell proliferation, platelet aggregation, monocyte adherence, vasoconstriction, thrombogenicity, inflammation, and an increase in free radical formation. Essentially, processes that maintain vasodilation and antithrombosis are altered. The presence of inflammation attracts monocytes or macrophages, which ingest lipids and become foam cells, which then release oxygen-free radicals. The release of oxygen-free radicals results in oxidation of low-density lipoproteins, which contributes to vasoconstriction, inflammation, and a prothrombogenic environment. The oxidized low-density lipoprotein is toxic to endothelial cells and fuels the atherosclerotic process. Next, lipids become trapped in the arterial wall with inflammatory infiltrates, forming a core. It's important to note that C-reactive protein pulls macrophages and cholesterol from the blood into the arterial wall. The higher the C-reactive protein, the more likely the plaque will rupture, even in the face of a low cholesterol. C-reactive protein correlates with a relative risk of increased incidence of coronary artery disease or myocardial infarction. As the plaque grows, smooth muscle cells migrate into the site, creating a cap, which stabilizes the core. These deposits, referred to as atheromas or plaques, protrude into the lumen, resulting in narrowed or obstructed blood flow. There are 2 types of plaques. The first is a stable plaque. Stable plaques have a thick fibrous cap, a small lipid core, are less likely to rupture, and produce narrowing of the artery that limits blood flow. It also causes shrinking of the vessel at the site of the plaque, referred to as negative remodeling. The second type of plaque is unstable. This type of plaque is vulnerable and is a large plaque within the wall of the artery. It has a thin fibrous cap that separates the core of the plaque from the lumen. Unstable plaques can cause the vessel to begin to expand outward, referred to as positive remodeling. The area most likely to rupture is the area between the plaque of the normal arterial wall, referred to as the shoulder. Once this plaque ruptures, the clotting cascade is initiated, and thrombus development occurs. Here is an image comparing a stable and unstable plaque. In the unstable plaque, you can see that it has ruptured and the clot In the unstable plaque, you can see that it's ruptured and a clot is forming at the site of the rupture. From this image, you can see how plaque formation will reduce blood flow, contributing to a reduced oxygen supply to the myocardium. This image provides an excellent depiction of the timeline of plaque development. A key point to derive from this image is that hyperlipidemia and atherosclerosis do not develop overnight. It's a process that occurs over decades. There are two possible outcomes of unstable plaque rupture. The plaque may rupture, resulting in the formation of a large thrombus, making the patient symptomatic. Often this is the basis of acute coronary syndrome, which includes unstable angina, non-ST elevation myocardial infarction, and ST elevation myocardial infarction. This will be the primary topic of the second part of this series. On the other hand, the plaque may rupture and a small thrombus may develop, in which case the patient is often asymptomatic. The plaque will become more fibrous and convert into a stable plaque. Now let's discuss the diagnosis of hyperlipidemia and atherosclerosis. In the past medical history, you want to note a history of a sedentary lifestyle, poor diet, smoking, diabetes, obesity, hypothyroidism, heart disease, hypertension, stress, and coagulopathy. In terms of the physical exam, there are a few findings that will suggest hyperlipidemia. The first is Xanthelasmas. This is a yellowing of the inner canthus of the eyelids. The second is Arcus Corneae, before the age of 45, because after that point it's normal. This is a white or gray opaque ring in the corneal margin due to cholesterol buildup. In the labs, you especially want to look at the lipid panel as well as the C-reactive protein. There are additional labs that kind of look at the past medical history. This image shows Xanthelasmas on the left and Arcus Corneae on the right. The lipid panel is key in guiding antihyperlipidemic therapy. It's important to be familiar with these laboratory ranges. An LDL of less than 100 is desirable, and less than 70 in a high-risk patient. An HDL of less than 40 in a male is considered low, and less than 50 in a female is considered low. Triglycerides should normally be less than 150, and total cholesterol should be less than 200. This is primarily just for your information and something you can try at home. The American College of Cardiology and American Heart Association devised a method of calculating atherosclerotic cardiovascular disease risk. It takes into account gender, age, race, high-density lipoprotein, total cholesterol, blood pressure, history of diabetes, hypertension, and whether or not the patient's a smoker. It provides an estimated risk as a percentage. This tool has been useful in determining whether or not the patient would benefit from antihyperlipidemic therapy. Now let's discuss the management of hyperlipidemia. Just as a reference point, for every 1% reduction in cholesterol, there's a 2% reduction in the risk of coronary artery disease. One of the primary goals in managing hyperlipidemia and atherosclerosis is to assist in the conversion of a vulnerable plaque to a stable plaque. Keep in mind that managing hyperlipidemia is only one aspect of this process. Let's first look at how we can modify risk factors to increase high-density lipoproteins and decrease low-density lipoproteins. Here's a list of risk factors for hyperlipidemia. Many of these we've already discussed. Of particular importance, these risk factors are modifiable and can be the target of care plans. Lifestyle modification is the first step of hyperlipidemia management. Both type 1 and type 2 diabetes increases the risk for developing atherosclerosis. These patients are at higher risk for developing atherosclerosis earlier. Insulin has been found to play a role in reducing endothelial dysfunction. For these patients, you want to target a hemoglobin A1C of less than 6 encourage PO and subcutaneous antidiabetic adherence, as well as adherence to diet. Hyperlipidemia and hypertension together can result in target organ damage. This comes in a variety of forms, including ventricular hypertrophy, TIA or CVA, peripheral vascular disease, renal disease, and retinopathy. For these patients, you want to monitor their blood pressure and encourage antihypertensive medication adherence. Obesity is defined as a BMI greater than 30 kilograms per meter squared. A 10% weight reduction has been associated with a 7 millimeter mercury change in the mean systolic blood pressure. Additionally, for every 10 pounds of weight loss, there is a 2 to 3 millimeter of mercury decrease in the systolic and diastolic blood pressure. I provided some quick formulas for determining ideal body weight and total caloric need just for your information. The following recommendations are from the JNC 8 guidelines, often referred to as the DASH diet. They encourage a diet rich in fruits and vegetables, low-fat dairy products, a reduction in total fat intake, a reduction in saturated fats, and the use of unsaturated fats such as olive oil, corn oil, canola, and safflower oil. I provided a little more detail on dietary recommendations in the following slides. The combination of the aforementioned conditions is referred to as the metabolic syndrome. This syndrome is defined as 3 or more of the following: abdominal obesity, an atherogenic lipid profile, hypertension, insulin resistance, or a pro-inflammatory state. Exercise has a variety of benefits, including the following: it'll increase oxygen supply, decrease workload on the heart, decrease oxygen demand, and increase the function of the myocardium. It's very common for patients to confuse the recommendation for exercise and interpret the recommendation as a need for strenuous exercise. However, benefits are achieved at low to moderate aerobic exercise. This can be done by 40 minutes of an aerobic walk 3 to 4 times per week, or 20 minutes of vigorous exercise 3 times a week. Patients should aim for 40 to 60% of their max target heart rate. This can be calculated by subtracting their age from 220. In other words, during exercise, patients should not exceed this max target heart rate. As a precaution, middle-aged males with a history of hypertension should undergo a stress test before changing their exercise regimen. Smoking-related disease accounts for 1/3 of all hospitalizations. Smoking results in reduced high-density lipoprotein levels, hydrocarbon and carbon monoxide injury that results in endothelial dysfunction, produces vasoconstriction, which increases afterload, increases catecholamines, which increases heart rate and blood pressure, and can produce dysrhythmias. A key assessment that may help with cessation is asking the patient when they had their first cigarette. Determine the pattern and break the cues. A nicotine patch or Wellbutrin may also be beneficial. Finally, stress can result in an increase in catecholamines, cortisol, vasopressin, aldosterone, and endorphins. All of these factors may ultimately increase systolic and diastolic blood pressure. Stress management is multimodal, and it includes relaxation, meditation, biofeedback, removal of stressors, changing the response to stressful circumstances, exercise, and medications. The last topic we will discuss is pharmacotherapy, which targets the endogenous pathway by targeting the gut and liver. This image is an excellent summary of the mechanism of action of a variety of anti-hyperlipidemics at various points in the endogenous and exogenous pathways. The first medication we will discuss is the HMG-CoA reductase inhibitors, commonly referred to as statins. These medications inhibit the enzyme HMG-CoA reductase, which is necessary for cholesterol synthesis by the liver. It also stimulates the synthesis of LDL receptors in the liver to facilitate clearance of LDL and VLDL. It's also been shown in literature to play a role in the inflammatory response and stabilization of plaques. Much of the current recommendations for statin use come from the 2013 American College of Cardiology and American Heart Association guidelines on the treatment of cholesterol. According to these two groups, initiation of statin therapy is optimal in the majority of patients. Statins are by far the best medications at reducing low-density lipoproteins. Commonly, the doses are broken down into three separate categories, whether they be high, moderate, or low-intensity statin therapy. It's interesting to note that each time you double the dose of a statin, you have a 6% decrease in LDLs. Statins will produce a difference in lipids within 3 months, and a difference in coronary artery disease risk in 5 years. Side effects to monitor for include myopathy or myalgia, which is muscle pain or tenderness, and statins can rarely lead to rhabdomyolysis, where you'll see a CK elevation or creatinine kinase elevation above 10 times the normal limit. Statins may also cause abdominal pain, nausea, vomiting, diarrhea, or constipation, as well as elevated liver function tests. In terms of monitoring, you'll want to keep an eye on the patient's liver function studies, as well as their lipid panel and creatinine kinase. It's important to take statins at bedtime because the liver processes more lipids between 12 and 5 a.m. These medications are contraindicated in pregnancy, lactation, and liver disease. If drug interactions are a concern, pravastatin, pitavastatin, and rosuvastatin are not metabolized by the cytochrome P450 pathway in the liver, so there's less interaction with other medications. The next class of medications are the bile acid sequestrants. These medications bind to bile salts, which contain high levels of cholesterol, in the gut to form an insoluble complex that cannot be reabsorbed. Therefore, you have reduced absorption of cholesterol. Side effects may include nausea, vomiting, diarrhea, and constipation, flatulence, and abdominal cramps. Bile acid sequestrants are contraindicated in biliary obstruction, abnormal intestinal function, and pregnancy or lactation. These medications should be taken before each meal and at bedtime. It is important to note, however, that they decrease absorption of other medications, so they should be taken 1 hour before or 4 hours after other medications, with meals, or mixed in water if it's powder form. It's also important to note that they decrease absorption of fat-soluble vitamins, A, D, E, and K. This is especially a problem if the patient is on a vitamin K antagonist such as warfarin or Coumadin, or they have a coagulopathy. Here I've provided you with some statistics regarding the changes in lipoproteins. I want to draw your attention to the fact that triglycerides are not affected. Unless they're elevated, then bile acid sequestrants might increase triglycerides. So these medications should not be used if the patient's triglyceride level is greater than 300 milligrams per deciliter. Cholesterol absorption inhibitors reduce dietary and biliary cholesterol absorption at the brush border of the small intestines. They reduce cholesterol stores and therefore reduce serum cholesterol levels. These medications are beneficial in the patient that cannot tolerate a statin or a statin's ineffective. Sometimes they're used in combination with statins as well. These patients may experience abdominal pain and diarrhea. Cholesterol absorption inhibitors are contraindicated in moderate to severe liver disease and pregnancy. It's important to note that they increase cyclosporin and warfarin levels in the blood, and they should not be taken at the same time as bile acid sequestrants. Niacin, or vitamin B3, converts small LDLs into large LDLs, which are less atherogenic. It also decreases catabolism of HDLs and inhibits adipose lipolysis. This medication may produce flushing due to the prostaglandin release and can be avoided by taking an aspirin or an NSAID 30 minutes before taking the niacin. Niacin may cause impaired glucose control and is a pregnancy category C at high doses. It's contraindicated in acute liver disease, peptic ulcer disease, and arterial bleeding. Fibric acid derivatives, or fibrates, increase lipoprotein lipase activity, resulting in an improved catabolism of triglycerides. These medications are primarily used in hypertriglyceridemia that does not respond to other medications. It's indicated when a patient's triglyceride level is greater than 500. Fibrates should be used cautiously with statins due to the risk of myopathy, rhabdomyolysis, and acute kidney injury. Liver function tests should be monitored because these medications are contraindicated in liver and gallbladder disease. Statins can reduce triglycerides by up to 50%. Out of the list of examples of fibrates, fenofibrate is the drug of choice if a patient's already on a statin. Omega-3 fatty acids, or fish oil, decrease hepatic production of triglycerides. They also increase triglyceride clearance and play a role in reducing inflammation. The patient may experience dyspepsia, nausea and vomiting, suppression of platelet aggregation, and elevated liver enzymes. It's important to note that it takes 1,000 milligrams at least twice a day to produce an effect. The over-the-counter fish oils only contain 200 to 300 milligrams. Some recommend that 2 servings of fish per week meets this requirement. However, it's difficult to meet the 2,000 milligram a day dosing to produce an effect on triglycerides. Often patients complain of the aftertaste that they experience with fish oils. If you freeze the capsules, it'll reduce the aftertaste. The last medication we will discuss is actually a new medication on the market as of 2015. The PCSK9 inhibitors are monoclonal antibodies that inhibit PCSK9, which regulates the lifespan of LDL receptors that clear cholesterol. When you inhibit PCSK9, you'll have an increase in LDL receptor density and an increased cholesterol clearance. This has been shown in studies to lower LDL to 30 to 40 milligrams per deciliter in combination with statins. This last slide provides a summary of hyperlipidemia treatment based on the targeted lipoprotein.